Thank you, everyone, and we will take a break for 5 minutes, and we'll be back. Stay tuned. Welcome back, our dear viewers. This is the second session of the conference, and I would like to welcome once again Dr. Ayman Rahmani, sharing this session on hematology in neonates. Welcome, Dr. Ayman. The session is yours.
Thank you very much, Ms. Amira. Welcome everybody to the second session of the first day of the conference. We shifting gears to hematology in neonates, hematology problem in neonates. We have three excellent speakers with us. We start the session with a dear friend and colleague, Dr. Mohammed Faisal Kanani. Dr. Faisal Kanani is the Chief of Pediatric Hematology and Oncology in Tawam Hospital in Al Ain. He's been with us at Tawam since 2014 as a consultant pediatric hematologist and then as a chief of pediatric hematology. Dr. Faisal, he's a fellow of the Royal College of Pediatrics and Child Health of London. He's a member of the Royal College of Physicians in Ireland, and he done his fellowship in pediatric hematology and oncology in a hospital for sick children in Toronto. Dr. Faisal is going to talk to us about common bleeding disorders in neonates and how to approach these neonatal bleeding disorders. Please join me. Welcome, Dr. Faisal Kanani.
Thank you for inviting me, the committee, Dr. Junaid, Dr. Ayman Rahmani, for giving me opportunity to speak in this NICU meeting for neonatal updates. So my topic is a diagnosis of bleeding disorders in neonates. From introduction, the range of PT and partial thrombopene extend above those for healthy adults. Even they are on upper side, there is no increased risk of bleeding in healthy newborn. And the platelets counts in the normal range. And platelet disorder may present during the neonatal period, but several factors make it difficult to establish. Therefore, it's difficult to establish a diagnosis. Therefore, of the neonatal hemostatic system with intention of identifying should be a problem similar to any other clinical problem in the neonatal periods. At birth, the concentration of vitamin K dependent are reduced to 50% of normal. Adults' value are further reduced in the preterm. And concentration of naturally occurring anticoagulant, antithrombin, protein C, and are low at birth. As a consequence of both prothrombin generation and thrombin inhibitions are reduced. Also, the plasminogen is low in the neonatal period in a low hypofibrinotic state. Despite this, few clinical can occur in the normal healthy neoterm infants. Hemostatic system mature after the birth, resulting in adult value by 6 months of age, and platelets count as normal. Despite this, bleeding time is shortened in von Willebrand disease because of the concentration of von Willebrand factor in higher, and also the PEG cell volume is on the higher side. So all of this, the bleeding time is shortened in the neonates. Now the causes of bleeding, you can go from coagulation defect. There is a defect, either quantitative or qualitative defects in the platelets, or fibrinolytic dysfunction. You can say vascular causes or miscellaneous. When you approach any neonates in a neonatal setting, you have to look two things. Is the baby sick or well before at onset of bleeding? Is the vitamin K given to the baby? Is bleeding generalized or localized? Or is there any family history or any history of maternal thrombocytopenia, or the mother is taking any medications or any Coumadin or any anti-epileptic or anti-TB drugs. And also the age of onset is also important of bleeding. Is straight away after birth or in first 4 to 6 weeks? Is the bleeding petechiae within small mucosal hemorrhage or as a bleed deep or large? Or are coexisting signs like a conjugated hyperbilirubinemia or organomegaly or sign of sepsis? So this is we learned from our books from physiology. This is like you have extrinsic and extrinsic pathway. In intrinsic pathway, we know that factor, you have a nucleotide activator and tissue injury lead to activation of 12, lead at factor 8 activation and factor 7 coming from extrinsic. Activation of prothrombin to thrombin by 10A and calcium, and fibrinogen to fibrin, and polymerized fibrin will be stabilized by a factor 13. And this is again, when any injury happens, the first thing is you have a vasoconstriction. And then the second part is platelets adhesions and aggregation. And then you have a secondary hemostasis, as I explained, tissue factor lead activation of coagulation, which lead to prothrombin to thrombin and fibrolysis. This is the normal coagulation cascade. Now, there is a different range. We have to remember that full-term infant, the range of PT is 15.9 to 10, and from 13 to 54. And even in premature, even the APPT 679.4 is normal. So when you examine, so the 39 PT is abnormal in older children, is normal in full term. So when you check, you need to make sure that you have a correct parameters, means when you are looking at a full term infant or looking at a premature infant and a normal older child. When you look at any patients, the basic thing is your complete blood count. You have to ask for smear. If you see giant platelets, maybe ITP or Bernard-Solier, then you see APPT and PT. This is with thrombocytopenia or no? Let go with, if you have thrombocytopenia, which is yes, then you have asked, is it prolonged PT and APPT? If it's both prolonged with thrombocytopenia, the commonest thing in neonates is sepsis. If it's no, then ITP, mostly from the mother or bone marrow or any occurred infection or thrombosis. If no thrombocytopenia, UCUF is either prolonged PT or APPT. When you come down here, if it's normal, then the factor 13 with delay umbilical cord and bleeding von Willebrand, platelets function, and vascular disorder. When you come with abnormal PT and normal APPT, then the commonest thing is either early liver disease, because in liver disease, both will be abnormal, and you have factor 7 or warfarin. And if you have normal PT and abnormal, the commonest thing is factor 8, 9, and factor 11, moderate to severe von Willebrand. If both is abnormal, the commonest thing, which we don't see now after with vitamin K, is mandatory for all the newborns, and I will discuss later on that, and the liver disease and DIC. Now, you have to look here if you see a sick patient with low platelets and abnormal PT, and PT, the commonest thing is DIC sepsis. Commonest thing is DIC, and DIC may be consequence of even sepsis. You see normal APPT, but later on they go on DIC and you get an abnormal. And when you have a normal platelets with both abnormal, either liver disease, and if any stress bleed is also common in neonates. If you have healthy newborn, if you have low platelets and both are normal, APPT, PT, look for acute infections, thrombosis, bone marrow infiltration. And if you have both prolonged hemorrhagic disease of newborn, and if you have abnormal APPT, which is hemophilia, and everything is normal, it's maybe a local trauma and not or factor 13 deficiency. The commonest thing is site of bleeding is very important. If you see it's only petechial, most is skin, or is a large. So normally petechial and mucosal bleeding is common in patients with quantitative or qualitative platelet dysfunction, and ecchymosis is in coagulation disorder. Bleeding after surgery or its delay, and also examples are when you have mucous membrane, you can with an ITP, or example in hemophilia A and B, you have this deep bleeding. The common coagulation disorder are either inherited or acquired. So when you have inherited, the commonest hemophilia A and B, von Willebrand disease, factor 7, 10, 12, and afibrinogenesis. When you come to the acquired, the commonest thing is liver disease, vitamin K deficiency, hemorrhagic disease of the newborn, warfarin overdose, and DIC. Now, when you come qualitative and quantitative, in our part of the world, and we have a consequence marriages where you have Bernard-Solier, common is Glassman, because it's common in some families, and we have dealing with around 20 to 30 patients, which is a very rare bleeding disorder, but also quantitative. If mother is ITP, it crosses the placenta, and also the other one is NAT when there is a PLA negative and positive, like an RH. The other one is common in either blood asphyxia infection can lead also to low platelets, and the other one congenital hemophilia. And if you are using heparin in the newborn for anything, it will give also heparin-induced thrombocytopenia. We have to keep in the mind about it. Now, the other vascular cause is either pulmonary hemorrhage. You can see in newborn or premature CNS hemorrhage, AV malformations, or hemangioma. The miscellaneous problem you see in a neonates, a rupture of spleen with liver with a breech delivery, retroperitoneal, intraperitoneal bleeding may be present in scotoecchymosis or subdural hematoma, cephalohematoma, subglial hemorrhage, and liver dysfunction. Now, some are unique in newborn because we know because of not closures of the sutures, you have an expanded cephalohematoma, prolonged circumcision after bleeding, which is the commonest presentation we see after patient with, especially with hemophilias, oozing from venipuncture site, bleeding from umbilicus and delay, which is in factor 13. And sick neonates can blood hematuria, mucous, intracranial, and pulmonary hemorrhage. So as we have to know is this is sick infection, you have to, it either is in a, most common is sepsis in a sick infection, which lead to DIC and liver disease. Well, infant vitamin K deficiency still, it's seen in the third world countries, and still it's when home delivery but vitamin K not given to the newborn. We'll discuss with later on. Platelet disorder can give you mycosis. Deep I explained before is common in clotting factor disorder. If you have huge spleen, you have to rule out congenital infection, jaundice, TORCH infection, or and also if you look in eyes, you have a retinal finding in TORCH infection. Now, prevention of bleeding, you know how you prevent the prevention of bleeding, you know, and normally the practice is to give 1 milligram vitamin K at birth to all babies from more than 1.5 kg, 1 milligram and 0.5 to all the babies. And if the baby is on TPN, broad spectrum antibiotics, you have weekly sometime, and give 10 milligram to mother if before delivery, if the mother is on any epileptic medications like phenobarb, phenytoins, taking anti-TB drugs, or getting coumarins like warfarin. The commonest dilemma, you know, as in the neonates or when as in a junior doctors that they face a solo blood syndrome when the baby or newborn passes the blood or bloody stool during the first couple of days of life. And then we have to know it's either from the mother, because normally from a fissure when the child is breastfeeding, or you confuse with the hemorrhage from the gut from the newborn. The simple test we should do, APTAS. APTAS is actually to rule out, we know that hemoglobin F, which is alkali resistance, and compared to the normal hemoglobin, which not alkali resistance. So simple way to rule out that if the child is well, only GI bleeding is noted, it's performed on a gastric aspirate or a stool. You can do in a labor ward that mix 1 part of bloody stool or vomit with 5 parts of water, centrifugate, and put 1 ml of non-sodium hydroxide to 4 ml of supernatant. So if the colors change from pink to yellow, it's maternal, and if the color same, it's look like a fetal. So it's very good test. It can be performed in the ward. The commonest thing you do with the test for platelets disorder, we don't do any more this bleeding time. The best thing is complete platelets count. And PFA 100 can be done in neonates now, but some lab have to be qualified and they have about the reading, you know, because there's a different reading of platelets function assay in neonates and children, which fortunately the PFA 100 and aggregations to be done in Tawam, and we are the only center at the moment doing it. And then the values are already verified and correlate with the normal ranges. Test for coagulation, like as explained, the intrinsic pathway, you have factor 7. Common is factor 8, 9, and 11, and 8 PT, which is factor 7 and 10. So factor 10 is both intrinsic, extrinsic, and thrombin time is the final step of coagulating cascade. And then fibrinogen and D-dimer. And other thing is the best is also look for a smear because it's very important in time when you're looking for DIC. You see a fragmented RBC and also granulation of platelets and also toxic granules. If the child have a sepsis can be seen in the white blood cells. Now the treatment, what you treat them, vitamin K, which is one dose we normally give if not given to the infants. If infant receiving TPN, they have to get it regularly. Ideally, vitamin K should be given for prolonged PT and APPD due to vitamin K deficiency with a minimal bleeding. But FFP, which is fresh frozen plasma, should be reserved for significant bleeding or emergency. Still, your test will come back. So when you see a patient, apart from do CBC, if require platelets, if CBC is normal, just give vitamin K and do all the basic tests, APPT and factors, and then give FFP in emergency measures. So FFP is actually 10 ml per kg given intravenously for active bleeding and repeated after 8 to 12 hours. And it replaces your clotting factor immediately till you get back your results. If there's no increase in platelet destruction, then 1 unit, which is equal to 10 to 15 ml of kg of platelets given to 3 kg infant, will rise from 50,000 to 1 lakh per meter square mm. So if no platelets are made or transfused, platelets count will drop slowly over 3 to 5 days. And the blood of donor should be matched for RH factor and typed and washed. We need to give a wash because RBC will mix in the platelets concentrate. Now then, when you find the deficiency, then you have to be given, depend upon if the child is diagnosed with hemophilia, you give the factor 8 or factor 9, depend upon the diagnosis. If severe von Willebrand is considered, you have to give plasma-derived von Willebrand factor. Chiroprecipitate is mostly used if you're suspecting afibrinogenemia or factor 13 for a neonate until a specific diagnosis is made. Now, let's quickly go with each disorders quickly. The A or B hemophilia is X-linked recessive disorder, mostly affect the male. Reports of females are rare if you have Noonan syndrome or unactivation 1X. Or most common disorder is hemophilia A, and then B, and both are deficiency hemophilia A for factor 8 and factor 9 for B. And they account for 90% of severe coagulation deficiencies. And they affect all the ratios group. Hemophilia may be undiagnosed, and they normally come at the time of crawl and walk. But as we know, that's most of the time circumcision is a common practice in our part of the world where you give vaccination, circumcision before discharge and then bleeding post-circumcision, and also the deep hematoma after the vaccination. The commonest, you see prolonged APPT be corrected by the mixing, and then you run your factor 8 and 9. Von Willebrand disease is the commonest with an estimated prevalence, 0.8 to 1.3, and autosomal dominant. It can give you superficial bleeding. Intracranial hemorrhage is only in type 3 that you can see intracranial hemorrhage. The commonest one is type 1, which is very mild type, can be present later on. But type 2B can come with thrombocytopenia. The diagnosis in type 3, which is typical like an hemophilia A, but you find a low level of factor 8 and von Willebrand factor, because von Willebrand carry factor 8. So that's why if the von Willebrand factor is not available, so nothing to be carry factor 8s. So always when you find a patient you're suspecting a newborn and hemophilia, make sure you also do von Willebrand antigen. Sometimes you can mix your von Willebrand type 3 because you keep giving factor 8, the child will not improve until you give a plasma-derived von Willebrand factor or you give FFP. And some cases of type 3, we also diagnose in neonates where there is a reduced von Willebrand activity. The management of DIC. Now, DIC is secondary phenomena. Management is reversible. And DIC is a condition when you have both clotting and anti-clotting consumed. So both there is a risk of hemorrhage and clot. Supported therapy with FFP, cryo, and platelets to maintain, because platelets consumed should be maintained above 50,000. And also FFP can be used to replace protein C and F, which also contain, FFP also contain protein C and antithrombin. Cryoprecipitate only best source of fibrinogen if fibrinogen is low. Exchange may be undertaken in a case of sepsis-induced DIC. As we spoke, is a clinical pathological syndrome with widespread intravascular coagulation that introduce baby appear very sick with petechial and GI hemorrhage oozing from manufactured side. You need to cover with, as we explained, to give FFP, platelets, and red blood cells, and you see fragmented RBC. And again, lead to progressive organ dysfunction, so we need to act very fast. The end result will be severe hemorrhage. Transient deficiency, procoagulant factor 8, factor 279, and anticoagulant may be attenuated by total administration of TPN or antibiotics or lack of administration of vitamin K to premature infants. Term infant may develop at day 2 or 3 if they were not supplemented by vitamin K. Mother might have received certain drug can induce vitamin K, as we explained, like phenytoin, phenobar. And disturbance of clotting may be associated, such as DIC due to infection, shock, anoxia, neck, renal vein thrombosis, vascular catheter, especially neonates. And the inherited abnormalities are the X-links, which we expose, like hemophilia or hemophilia B, autosomal dominant is von-Willebrand disease and dysfibrinogemia, autosomal recessive deficiency of factor 11, 7, 5, 10, and 2, and fibrinogen, and 13 are all by autosomal gene. So this is intrinsic pathway we explain again. So heparin can increase your APPT, and then because factor 7 is vitamin K dependent with the shortest half-life, the PT is used to treatment for patient with vitamin K agonists when you for warfarin or also for inherited disease of newborn, and again hematological consequence to the fetus due to metal and disease. True metal and disease influence the hematological consequence in the fetus. Diabetes, polycythemia can give thrombosis in a newborn. Hypertension in the mother can lead to neutropenia and thrombocytopenia. SLE in the mother can lead to thrombocytopenia and thrombosis. Smoking can lead to polycythemia. Medication, if the mother is taking, can affect on hemostasis. If mother have on chemotherapy, can induce thrombocytopenia. And intrauterine infection, which is anemia, thrombocytopenia, and consumptive coagulopathy, can be a cascade of intrauterine infection. The acquired clotting deficiency, hemorrhagic disease of the newborn, and is typical, still is present, the third part, and still there, is a moderate transient deficiency of vitamin K dependent factor, reduced body store of vitamin K due to lack of free vitamin K in the mother. More common in the preterm. No vitamin K administration after birth. Breast milk is a poor source, more common in breast than a formula feed one. It's because the liver is not immature or the disease or malabsorption, absence of bacterial intestinal flora that form vitamin K, like in TPN or somebody in child on broad spectrum antibiotics or medication induced. So early, which is least common form, onset within first 24 hours, bleeding pattern is variable but can lead to serious intracranial hemorrhage. Warfarin, anticoagulation drug or anti-TB, and mother was on management. At risk mother should be given vitamin K orally for 15 to 30 days before delivery if the mother is using warfarin or anticonvulsant or anti-TB drugs. And when warfarin is to prescribe, it advised that is to be avoided between week 6 to 12 of gestation, because mother, if have any deep vein thrombosis, so they cannot stop warfarin, but it need to be avoided and need to supplement by other things. But and close to term when you have a risk of neonatal bleeding. Classical, which is typical, a classic book where you see in exam questions where estimate frequency is very considerably from 0.25 to 1.7%, particularly in the mother of, and it's common when this delivery at home, which is third part, where home delivery, where vitamin K was not given, and also the baby or exclusive breastfeed. Typically present day to 5 who appear otherwise well, home delivery, typically on all breastfeeding, come with bruises, purpura, GI hemorrhage as a typical presentation, bleeding from umbilicus and mucus, but ICH may be infrequent compared to the early one. Management vitamin K, you need to give the clotting factors and supportive treatment. Late breastfeeding and failure to receive advert are frequently documented risk factor, can occur in week 4 to 12 weeks. And also this is common if infants are on antibiotics or with malabsorption, or those who have a liver or disease of cystic fibrosis. And vitamin K weak for first 3 months of life may prevent late hemorrhagic disease of newborn. So this is my references. I will stop my talk here. If any question, we'll take. Thank you very much.
Thank you very much, Dr. Faisal, for a very detailed lecture about the very important problem in neonates. We're going to stay in the field of hematology with the next speaker. It's my pleasure to introduce Dr. Ashish Kumar. Dr. Ashish Kumar is Director of Histocytosis Center and Hematology Oncology Fellowship Program at the UC Department of Pediatrics, Cincinnati Children's Hospital in Ohio, USA. Dr. Ashish is a professor of pediatrics at the University of Cincinnati, and he is the co-director of the Histocytosis Center of Cincinnati Children and director of fellowship training program in pediatric hematology oncology. Dr. Ashish will talk to us about a very rare occurrence in neonate, but very important, which is hemophagocytic lymphohistiocytosis. From now on, I'm going to call it HLH for short. And he's going to give us some details about recognizing and making diagnosis and management. Welcome, Dr. Ashish. It's all yours now.
Good afternoon. Thank you for inviting me to share some of my knowledge about this condition that, as you heard, it is quite rare, but it is quite important to know. And let's keep it brief and call it HLH. It's much easier to talk about, say it as HLH. And then before I begin, just a few disclosures. I have done some consulting work with these companies, Novimmune and Sobi, and there might be some off-label use description of these medications as well. So what is HLH? Because you are neonatologists, you probably have heard the other HLH, hypoplastic left heart. That is not what we're talking about. So it's a big word, hemophagocytic lymphohistiocytosis. This has nothing to do with another histiocytic disorder you may have also heard about, LCH. These are completely unrelated disorders. But let's break down the word. So the word hemophagocytic comes from heme, which means blood, and phagocyte is a cell that eats other cells. So that's the word hemophagocytic. Lymphocytosis means expansion of lymphocytes, and histiocytosis means expansion of tissue macrophages. Those are the histiocytes. So that's where the disease gets its name. And so this is what hemophagocytosis looks like under the microscope in a bone marrow biopsy. Shown here is a large macrophage, which I'm outlining with the laser pointer, and inside the cytoplasm of this macrophage are other cells that the macrophage has ingested or eaten. So this is the hallmark that gave the disease its name. But let's dig deeper. That still doesn't tell us what this is. The most important thing to remember is that HLH is not a single disease entity. It is not a diagnosis in itself, but rather it is a clinical description or manifestation of many underlying diagnostic entities. And what all of these diagnoses share in common is extensive systemic inflammation that involves lymphocytes and macrophages. There is a condition known as primary HLH, and that is caused by congenital or genetic deficits in the cytotoxic immune response. And I will get into a little more of the details of what this means. how does extensive inflammation manifest itself in all of these conditions? It starts off, we know that in all of these conditions that give rise to the manifestation of HLH, there is activation of macrophages. These activated macrophages eat blood cells that leads to cytopenias. So thrombocytopenia, anemia, neutropenia, usually all blood lines are affected. The macrophages invade the liver, causing inflammation of the liver or hepatitis. And for whatever reason, there is a consumption of fibrinogen. So you end up with a consumptive hypofibrinogenemia. So these are the clinical manifestations which are caused by, all can be related to activated macrophages. Why are the macrophages active? Because there are inflammatory cytokines that are activating the macrophages. Where do these inflammatory cytokines come from? They come from activated lymphocytes. So this is the main problem. You have extensive activation of lymphocytes. These lymphocytes release cytokines. Those cytokines do two things. They activate lymphocytes again, so there is this vicious loop. And then they also activate macrophages, and then these activated macrophages cause these symptoms. This is not a new disease. It has been known for a while. It was first described in the journal Lancet. And this patient that was described in this paper, the paper was published in 1939, but the patient was described was originally seen in 1929, so it's almost 100 years ago now. The first description was found in the literature. And this patient was described as having fever, wasting, splenic and hepatic enlargement, jaundice, purpura, anemia, leukopenia, and then phagocytosis. So these are the same clinical manifestations that we now recognize in this disease. And it was a few years later, it was found that this could be familial when two infants in the same family were described who had similar features. This was, in the 1950s when these drugs that we have nowadays did not exist. And so this has been known for a while, but then finally the Histiocyte Society came together and in the 80s and 90s came up with this terminology of HLH. The Histiocyte Society also came together to come up with diagnostic criteria, and they conducted a clinical trial that was called HLH-94 because it was 1994 when the trial started. It was in 1999 that the first genetic defect mutations in this gene called perforin were identified. And then in the year 2004, the diagnostic criteria were revised, and the next clinical trial initiated called HLH-2004. And the diagnostic criteria from HLH-2004 is what most physicians use to diagnose HLH today. So what are those criteria? And those are listed here. There are 8 features, and for the HLH-2004 clinical trial, if a patient met 5 out of these 8 features, they met the diagnosis of HLH. And this was fever, splenomegaly, cytopenias affecting 2 cell lines, elevated triglycerides or reduced fibrinogen, presence of hemophagocytosis in the bone marrow, spleen, or lymph nodes, a decreased NK cell activity, elevated ferritin, or elevated soluble CD25, which is also known as the IL-2 receptor alpha. If 5 out of these 8 features were present, in the absence of a malignancy, the patient was said to have HLH. Now, so this is the dogma that is still practiced, that if the patient meets 5 out of 8 diagnostic criteria, they meet the definition of HLH. If a genetic mutation is identified, we now know of several genes that lead to HLH. It is called primary or familial HLH. If there is no mutation, it is considered to be secondary HLH. And if the HLH recurs after treatment, it is again labeled as primary. That means there's something intrinsically wrong with the patient's immune system. The problem is that those criteria were established in 2004, that was 17 years ago, we now know a lot more about the disease, and we know a lot more about the manifestations of other diseases that can be confused with HLH. And I will illustrate that with some examples. And so this is the one that is most relevant to this audience. And this is a true case, and I have several like this. So we got a call about from a newborn IC from our NICU saying that there was a full-term baby male who was born and found to be in respiratory distress, and there was very difficult to revive, and eventually ended up having to be intubated. And they found that there was a massive liver and spleen enlargement, also noted to have petechiae, and that led to the CBC, which showed the baby had pancytopenia. And so they suspected sepsis. All cultures were drawn and antibiotics were given, but it made no difference, and the cultures were negative. But because of the hepatosplenomegaly and petechiae, a bone marrow biopsy was done, which actually showed hemophagocytosis. So when they put that, they started thinking, could this be HLH? Because we at Cincinnati Children's, everybody thinks of HLH. And so they checked ferritin, it was elevated. They checked soluble alkaline receptor, it was very high. The fibrinogen was not low, but it was not elevated either, it was just normal. So we have a baby now who has splenomegaly, which is one of the features, has cytopenias, pancytopenia, elevated ferritin, elevated soluble alkaline receptor, and they saw hemophagocytosis in the bone marrow. And so met the diagnostic criteria, and that's what they called us. Now, remember, no ident infections were found, and the HLH markers are elevated, so they initiated treatment with dexamethasone. But fortunately, in one of the very attentive nurses in the NICU noticed that there was a small lump in the baby's axilla. So it turns out this was an axillary lymph node. That is highly unusual. It is never found in HLH. So they got a lymph node biopsy, and turns out this baby actually had a lymphoma. It's extremely rare, but newborn baby with a lymphoma, I guess it can happen. And we subsequently have identified several such children. Two of them were newborns. This child had a lymphoma, another baby had a leukemia, that were all initially labeled as HLH, and they were all treated. But some of them were older children as well, and they were all diagnosed and treated as having HLH due to the HLH 2004 criteria, but they all had either underlying malignancies or infections. So we published one paper, this was in Pediatric Blood and Cancer now 3-4 years ago. And in this paper, we described 9 such patients, and unfortunately, only 1 is surviving. All the other 8 patients died because they did not get the right treatment up front. So let's go back and visit this pathogenesis of HLH. And if you can imagine, lymphoma is a collection of activated young lymphocytes that could lead to the same consequences of activation and then the clinical features that are described. So what is primary HLH? Why do we care so much about this? Why is this concern? And in order to understand that, let's briefly review the normal immune system response. So if we go from left to right in this diagram, if there is an invasion or abnormal activity in our body, such as a viral infection, the antigen or the first cells that encounter it, neutrophils or macrophages or any other type of cell, they present this antigen to cytotoxic lymphocytes, shown here as CD8 T cells as an example. In response to this activation, the T cells will expand, they will become activated, and they do 2 things. One is they secrete cytokines such as interferon gamma, and the second is that by direct contact with the antigen-presenting cell, they kill the cell, and with that, the virally infected cell is killed, so the virus is eliminated. So you have clearance of the virus, and once these antigen-presenting cells are removed, they are no longer stimulating the T cells, so the immune response is also terminated. these T cells are then, they shrink and they are saved for future use if the same virus is seen again. Now, what if this process goes wrong? And specifically, I'm talking about what if the lymphocytes cannot kill the infected cell? There are two problems. One, that these cells and the infections, they persist. And as long as they persist, they will continue to stimulate these T cells. These T cells will, they cannot kill, but they can secrete lots and lots of cytokines such as interferon gamma. And as they continue to be stimulated, they expand and they infiltrate other organs. And then these cytokines will then activate the macrophages. Those macrophages themselves will secrete additional cytokines, and now you're stuck in this vicious loop of activated lymphocytes, lots of inflammatory cytokines, and activated macrophages. This is what happens in primary HLH. So shown here is a detailed view of how the cytotoxic lymphocytes kill the target cell. They do so by creating an immunologic synapse, which is similar to the neurologic synapse, where two cells make contact, but there's a small gap in between. And the cytotoxic cell will then release the contents of these cytotoxic granules. In these granules are two chemicals. One is perforin, which is a protein that makes a pore or perforates the target cell, the target plasma membrane, through which will enter granzyme, and that will destroy this cell. So if the cell on the left, which is shown in green, the killer cell, cannot release perforin granules, or if they don't have perforin, then the cell on the right, which needs to be eliminated, the target cell, will not be eliminated, giving rise to HLH. So if the cell does not have perforin, it can release all the granules, but it's like you're shooting with a gun, but your bullets they are blanks. They don't have any ammunition in them. That is what, if you don't have perforin, that was the first genetic defect that I mentioned earlier. But there can be several other problems, and that is the cell may have the perforin, but it cannot move these granules from inside the cell into the synaptic space here. And so that process requires many different proteins. There's a very complex signaling mechanism that tells the granules to move from inside the cell into the space, the immunologic synapse space, which is shown here in the middle. And I have underlined in red all the proteins that we now know that have been found deficient in children with the HLH. And this is important because majority of these genes, these genetic defects, are autosomal recessive. And so many of these genes were actually identified only because of the cultural practices of consanguineous marriages, where autosomal recessive diseases then come forward, because majority of us carry a single allele or many different mutations, but we are carriers because a single allele does not manifest the disease. But we now know of all of these genes, majority of them are autosomal recessive, and when you have two defective alleles, you manifest the disease. Two of them are actually X-linked, and so only boys will be affected, but many of these can be manifested very shortly after birth or in the first year of life. So this now allows us to expand the pathogenesis. So we know that the cytotoxic lymphocytes will become activated if they cannot kill the target cell. And so the lack of killing of target cell can now be traced all the way back up to either absence of perforin, absence of one of these signaling proteins called SAP. This is on the X chromosome. So the disease is also known as XLP1, X-linked lymphoproliferative disease, but this is the name of the protein or the gene. And then all the genes that contribute to the the cytotoxic granule secretion. If you're missing any of them, you cannot kill the target cell, and if you cannot kill the target cell, those lymphocytes are activated. We now also know that the second X-linked gene that I mentioned, called XIAP, And there is another one that was described recently in the literature called NLRC4. These genes control a new type of organelle in the cell called inflammasome. We all need inflammasome to protect us against viruses and bacteria by just upregulating inflammatory systems in our cell. These genes, XIAP and NLRC4, are components of the inflammasome and they keep it under control. If you have mutations, either loss of function mutation in XIAP or gain of function activating mutations in NLRC4, the inflammasome is always active. And that leads to large-scale secretion of this cytokine called IL-18, which then does the same thing, activates lymphocytes. So there are many now known genetic disorders that will cause HLH in the baby. And because of these findings, we now have new tools and understanding. We can now identify lymphocyte activation very quickly and reliably using this marker of soluble IL-2 receptor. So this was included as in the 5 out of 8 diagnostic criteria. So if the patient had 6 or 7 criteria met, because all you need is 5, they will be diagnosed with HLH. But if the soluble IL-2 receptor is normal, then it is not HLH because it means that the lymphocytes are not active. And remember, in HLH, the lymphocytes must be active. Another new marker is this cytokine called CXCL9, which is a marker of interferon gamma activation. And so if you recall, I told you that it is the cytokines such as interferon gamma that are secreted that are important in the pathogenesis. So we can measure, sometimes you can measure interferon gamma, or easier to measure CXCL9. And we now also have flow cytometry-based assays that allow us to measure perforin, the 2 X-linked proteins, and the whole movement of the cytolytic granules. All of this can be measured with flow cytometry very quickly. So here is one example of the flow cytometry analysis of perforin. So on the top is a normal individual, and what we're looking for is the red histogram. So this is the NK cells of a normal individual. The red line indicates the presence of perforin in the NK cells. The bottom row is that of a patient, and if you see, there is no perforin. And this assay takes about 24 hours to run, and you can get an answer that not only does the child have perforin, you've also diagnosed the cause of HLH, the absence of perforin. We have similar assays for SAP and XIAP, which are the 2 X-linked proteins. And then finally, you can measure the entire lytic granule secretion by this assay, which measures, it's called CD107A. And so this is the lytic granule inside the cell. Normally, this protein called CD107A is only present inside the granule. It is not on the cell surface. But when the granule empties its contents in the synapse, CD107A now is exposed, and you can identify that using a fluorescent labeled antibody in flow cytometry, and that can be detected readily here. So on the top is a normal individual. If you look on the left graph, there is no CD107A on the cell surface. It should be on the right here. But when you stimulate these cells now, CD107A is exposed. On the bottom row is a patient with primary HLH. Again, at rest, there is no CD107A, but even after stimulation, there is barely, almost no CD107A detectable. And this is how we actually diagnosed a homozygous mutation in a gene called STXBP2 in this patient. So the advantages of the flow cytometry assay is that this is a functional assay, the CD107A, and you can measure the function of 5 genes simultaneously. So if CD107A is normal, then we know that all these genes, they are normal, they're functioning normally. If it's abnormal, it's one of these 5. So with these flow cytometry assays, we can now rapidly and reliably diagnose primary HLH. You can still do genetic testing, and we still do them, but the problem is that you cannot rely solely on the genetic test. One is because HLH is autosomal recessive. So if you find one mutation, then you are left confused. You don't know, is this the cause of the patient's illness? We don't know all the mutations So sometimes we find something that is an abnormal sequence, but is that a normal variation or is it a mutation? That is sometimes very difficult to tell. And these results take 4 to 6 weeks. And if you have a sick baby in front of you, you cannot wait 4 to 6 weeks to confirm whether this is primary HLH or not. We also find that, remember I told you, the disease got its name from hemophagocytosis. Turns out that it is not specific to HLH. This can be seen in many, many conditions, sometimes even normal bone marrow. And in many children with primary HLH, this is actually never seen. So we don't use this as a criteria anymore. And if you recall the 8 criteria that were listed, one of them was this thing called an NK cell function assay. First of all, it is a very challenging assay. It is not available in most laboratories. Even in the United States, there are only 2 or 3 labs in the entire country that will do this. One of them is ours. What we've learned is that it's a very non-specific assay. So half the time it gives you an abnormal result, regardless of what the patient's diagnosis is. So we don't use this anymore. And so basically what I'm trying to tell you is that the HLH 2004 criteria may have been appropriate back in 2004, but now that we know more about this, what we are learning is that an elevated ferritin does not matter how high. There are some papers that mention that the ferritin above 10,000 is more specific to HLH. In our experience, that is not true. Even though I mentioned soluble alpha receptor is a requirement to diagnose HLH, it also is not specific. You cannot diagnose HLH without elevated soluble alpha receptor, but just because it is elevated does not guarantee that it is HLH either. And if you all recall, fever, splenomegaly, cytopenias, these are features of many infections, and sepsis sometimes can give rise to that. And of course, leukemias and lymphomas, like I've already mentioned. In the HLH 2004 criteria, also not included are these challenges that if the fibrinogen is normal or elevated, it is almost never HLH. If you have a high white count, usually it is sepsis or leukemia. But the criteria don't mention that if you have a white count, it cannot be HLH. And as I showed you by an example, that lymphadenopathy is almost never seen in HLH. So if there's a lymphadenopathy, usually we're dealing with something else. So I'll give you one other example. Another full-term newborn was diagnosed with HLH, and that's because, again, a male found to be jaundice at day 14 of life, so a little late for the usual causes of jaundice. And then we're found to have hepatomegaly, thrombocytopenia, and leukopenia. All the cultures were drawn and antibiotics were given, but that was negative. And then he was noted to have elevated ferritin and elevated soluble alpha receptor. Initiated HLH therapy, but his condition continued to worsen. And so they transferred this baby to our center, and shortly after arrival, the baby died. And basically what he had was disseminated herpes simplex, which is a treatable condition and can manifest with the same features that we find in HLH. And again, just like this one, we have now identified several infections that were confused as HLH. And so the criteria, the diagnostic features, what they describe is just systemic inflammation. And that can happen if you have a primary defect in the immune system. Even with a simple virus, you can get full-blown inflammation causing HLH. Or if you go in this diagram all the way to the left, you may have a completely normal immune system, but a very inflammatory stimulus, such as lymphoma. These are all the infections that we commonly see that can cause HLH. And I'm sure there are others, HSV I did not put on there, but sometimes that can do that. So histoplasmosis, ehrlichiosis, dengue, all of these can do that. And so it's the same thing, like I mentioned, lymphomas or many infections or some other inflammatory causes. All you need is a release or a large bucket of inflammatory cytokines that has been dumped in the blood. And now you get activation of lymphocytes, which then release more inflammatory cytokines, and then you get activation of macrophages, which then leads to clinical manifestations of HLH. So all roads can lead to HLH, and these are the diseases that we know of that can lead to the manifestation of HLH in children, adults, in newborns, We've seen all of these conditions. And this is important because the current recommendations are that if you don't have a genetic defect, then it is secondary HLH. And the current recommendation is that the initial therapy should be the same for all children with HLH, whether it is primary or secondary, and that treatment should not be delayed. But here's the problem. When the treatment is tightly coupled to the diagnosis and the obvious diagnosis has been accepted, the outcome will be catastrophic. And so the treatment for HLH, most people will use etoposide plus dexamethasone. Our French colleagues use ATG plus prednisone. There are many other diseases, treatments described in the literature as anakinra, alemtuzumab. These are just some examples. Because if you have familial HLH, when you give them these immune suppressive therapies or chemotherapy, you are putting out the fire. But if you have infection, you're actually fueling the fire, only making things worse, like we saw in the baby with the herpes simplex infection. Same thing if you have a malignancy such as leukemia or lymphoma. When you give such a child dexamethasone and etoposide or any of the other treatments listed, you do get temporary response, but that is actually only a false sense of security. What you're doing is selecting for clones which will actually then give rise to a harder to treat lymphoma or leukemia. And just because the patient responds to immunosuppressive therapy does not mean that they have HLH, because many inflammatory infections such as viruses, mycobacteria, leishmania, and many neoplasms I've already mentioned, they are hyperinflammatory and they will respond to short courses of steroids. But that does not mean that the child has primary HLH or that they don't have an infection. And so I've already mentioned that many leukemias and lymphomas look like HLH. And so just because, and if you don't treat the underlying condition, the HLH will recur. So just because it recurs does not make it primary HLH. So what I've tried to convince you is that the diagnostic criteria that we consider HLH 2004, I would not say they are diagnostic. They should raise the suspicion for HLH, but it is not sufficient to diagnose HLH just based on those criteria. We need more. And so when to think of HLH is anytime you have a child with prolonged fever, inflammation of the liver, reduced fibrinogen, and you've made sure there is no infection, no leukemia or lymphoma. Elevated ferritin and cytopenia should make you think of it, but it's not sufficient to diagnose. If there is a family history of unexplained death in childhood, unexplained liver disease, inflammatory bowel disease in young boys can also be a sign of HLH. And clues that it may not be HLH are elevated white count, normal fibrinogen, normal soluble alpha receptor, if you have that. The presence of positive DAT or Coombs test, lymphadenopathy, and a normal liver enzymes, they should all make you suspect that this is not HLH. So this is our algorithm. I just show it on here because it is freely available on our website. If you just Google HLH Cincinnati, you will find this on our website, and you can download it, use it to, if anybody suspects HLH, whether it is in a baby or in any other child. And so we in Cincinnati, we wait for the test results. We don't jump to the diagnosis based simply on those criteria. Unfortunately, many times this happens on a Friday afternoon or a Sunday when we don't have testing available. So we sometimes will start with dexamethasone and wait to add etoposide if we need to. If the genetic testing comes back as negative, then we have to stop therapy and find what is it that we're missing, the malignancy or infection. I will actually skip this last part in the interest of time, and I will end here. Just note that the definitive treatment for primary HLH only is bone marrow transplant. There are newer ways of transplanting children that have become safer and more effective that we continue to explore. And with that, just summarizing that the HLH 2004 criteria are not HLH. All these clinical features just describe systemic inflammation. Always think of malignancy and infection even in a newborn. And if you have anybody ever has a question, feel free to email us. This is the email address, hlh@cchmc.org. We monitor this email every day, and we will be happy to respond and answer any questions and help you out with your diagnosis dilemma. Thank you, and I will be happy to answer questions at the end.
Thank you very much, Dr. Ashish, for interesting presentation that shed light on a very rare but a serious disease in newborn. We stay in the field of hematology, and I would like to welcome Dr. Dalal Taha. Dr. Dalal Taha, attending neonatologist, division neonatology at Jill and Mark Fishman Center for Lymphatic Disorder. She's assistant professor of clinical pediatrics at Perelman School of Medicine at the University of Pennsylvania, USA. She's a graduate from the same program that I graduated from, UMGNJ, formerly known, and at Rutgers University. And she finished medical school at Rwan University at Stratford, New Jersey. She's currently working at the University of Pennsylvania as assistant professor in clinical pediatrics. Dr. Dalal will present to us an update on the management of neonatal lymphatic disorder. Please join me. Welcome, Dr. Dalal Taha.
Good afternoon. I'd like to thank the organizers of this conference for inviting me to speak to you today on neonatal lymphatic disorders. I used to refer to the lymph system as a forgotten circulation, but I don't think that's true anymore since over the last few years we've improved our recognition of these disorders, especially in the neonatal population. I have nothing to disclose. My objectives are to review the lymphatic imaging and interventions. I'll also go over types of neonatal lymphatic disorders that we diagnose and discuss some of their outcomes. Before I get into imaging and interventions, I wanted to review lymphatic anatomy. Approximately 80 to 90% of the lymph in the body is generated below the diaphragm, mainly from the liver and intestine. The lymph vessels from the liver, intestine, and soft tissue all converge at the cisterna chyli, which then sends the fluid up towards the central thoracic duct. The thoracic duct conducts lymph into the venous system through the innominate, subclavian, or internal jugular vein. Lymphatic fluid is made up of white blood cells with a lymphocyte predominance, immunoglobulins, proteins, coagulation factors, and triglycerides. Fluid that is suspected to be lymphatic in origin is generally tested for lymphocyte count, albumin, protein, and triglyceride level. Some patients who have a high volume of lymphatic drainage may actually present with either coagulopathy, immunodeficiency, or hypoalbuminemia. We know that lymphatic vessels contain valves similar to those in veins, and they maintain a unidirectional flow of fluid towards the central lymphatic system. The video on the left here shows the contraction of muscles within the lymph vessel wall, and fluid is being propelled through the valve in one direction. The blue arrows in the fluoroscopic image on the right are pointing to the valves within the lymph vessel. Factors that affect the flow of lymph include pulmonary blood flow, intrathoracic pressure, central venous pressure, disruptions in lymph channel formation, certain medications like furosemide, activity, and diet or fluid intake. In a study using a lamb model, it was found that chronic increases in pulmonary blood flow led to lymphatic congestion and decreased flow through lymphatic vessels. Increases in pulmonary blood flow over time also caused structural changes in the pulmonary lymphatics, and these vessels became larger and more dilated.
When we suspect a lymphatic flow disorder, we try to obtain imaging, which we hope will help us make a diagnosis. I'll go through these different types of imaging techniques. Non-contrast T2-weighted MR lymphangiography is the only non-invasive method of imaging the lymphatic system. Slow-moving, non-bloody fluids produce a high T2 signal and are therefore easily visualized on MRI. This technique has typically been used to assess the anatomy of the peripheral lymphatic system in patients with lymphedema, but can also be used to diagnose lymphatic malformations as well as see segments of the central anatomy, including the thoracic duct. The limitation to this type of imaging is that it doesn't provide any information about lymph flow, and the lack of contrast does make it difficult to see the smaller channels. There are 4 types of lymphatic abnormalities that we can see on T2 imaging. Type 1 is essentially normal. When there's perfusion into the supraclavicular region, it's called type 2. Type 3 is abnormal flow extending to the mediastinum, and if the abnormalities also include the lungs, it's type 4. So minimally invasive method to image the lymphatic system is through intranodal lymphangiography. This technique begins with inserting small needles into the inguinal lymph nodes. Through these needles, contrast is then injected and the lymphatic system is imaged fluoroscopically or with MRI. The image on the right is an ultrasound view of the lymph node highlighted by the white star, and this white arrow is pointing to the needle that is entering the lymph node. Lymphatic imaging that requires intranodal access is typically performed in an XMR suite like the one pictured here. The inguinal lymph node needles are placed in the first part of the suite on the left. Once needle position is confirmed, the table that the patient is secured on can move along a track into the MRI scanner, or they may stay stationary if it's undergoing fluoroscopic imaging. If the patient is to be moved into the MRI scanner, gadolinium is then injected into each lymph node. 1 minute after the initiation of injection, scanning is started. These images show a typical time course of contrast moving along the central lymphatics, with image C showing the thoracic duct lit up in a normal person at 430 seconds, or about 7 minutes. Imaging the flow of fluid within the lymphatic system using MRI is called dynamic contrast enhanced MR lymphangiography, which is also referred to as MR lymphangiography or DCMRL. This video shows the pattern of flow from the inguinal nodes up to the thoracic duct in real time. After DCMRL, if a more detailed look at the thoracic duct outlet is needed, we proceed to direct lymphangiography. In this technique, the lymphatic system is accessed transabdominally using a 21 or 22 gauge needle. To prevent leakage of chyle from the cisterna chyli, access to the lymph system is obtained through feeder vessels just below the cisterna chyli under fluoroscopic guidance. Using this access, a microcatheter is then inserted directly into the thoracic duct and contrast can be injected. A newer alternate method to assess patency of the thoracic duct outlet is by using contrast-enhanced ultrasound. Using the inguinal needles that were placed for DCMRL, ultrasound contrast is injected, followed by imaging of the left or right neck until the contrast appears. These images were taken from a 2020 study describing contrast-enhanced ultrasound. Image A on the top of the slide is the ultrasound view of the left internal jugular vein and proximal innominate vein before contrast injection. In image B, the arrows pointing to the passage of contrast into the left internal jugular vein, and the arrowhead is showing the contrast then extending into the innominate vein. These findings confirm the patency of the thoracic duct outlet. Image C is the DCMRL from the same patient. The arrow in this image is pointing to the thoracic duct, but because of the abnormal lymphatic networks up in the neck, the outlet was not able to be visualized on this imaging. So once we visualize the disruption of the lymphatic system with one of the imaging techniques I described, we can determine if any intervention is the next best step. So I will review lymphatic embolization, specifically oil injection, as well as lymphovenous anastomosis and thoracic duct externalization. Embolization begins with inguinal lymph node contrast injection so that the thoracic duct can be visualized. Once there is opacification of the lymphatics seen in this image on the left, a needle can be introduced transabdominally to access the thoracic duct. A wire is then placed over the needle and advanced to the site of the abnormality. The image on the right shows leakage of contrast at the top of the thoracic duct, and so this is the area in which the coil or glue may be deposited. The same technique is used to selectively embolize abnormal vessels that branch off of the thoracic duct. Thiodized oil can also be used for selective embolization of lymphatic channels and is commonly the treatment of choice for chylothorax. This oil is a radio-opaque contrast agent that is made up of iodine or poppy seed oil and has been in use since the early 1900s. Due to its high viscosity, it results in mechanical occlusion of abnormally conducting lymphatic vessels. It is also believed that it causes an inflammatory reaction within the vessel wall, resulting in the sclerosis. This type of treatment also requires inguinal lymph node access for it to be injected. Image A shows the contrast moving up the lymphatics towards the cisterna chyli early during the lymphangiogram. Image B shows the oil migrating into the abnormal pulmonary lymphatic vessels, and image C shows the appearance of the retained oil on X-ray. If a thoracic duct outlet obstruction is found on imaging, the treatment may be a lymphovenous anastomosis. In this intervention, a lymphatic vessel in an affected area of the body is connected to the venous system in that same area. This allows the excess lymph to drain directly into the venous circulation, bypassing the abnormalities. Historically, this technique has been used for many years to treat adults who undergo lymphadenectomy for cancer and then go on to develop lymphedema. More recently, this technique has been used in infants who have had thoracic duct outlet obstruction. In 2018, Weissler and colleagues reported on 2 successful cases of lymphovenous anastomosis done at the Children's Hospital of Philadelphia. Both were infants who had congenital heart disease and developed chylothoraces after cardiac surgery. One of the infants developed a venous clot, and the other infant's thoracic duct was disrupted during the surgery. During this procedure, the lymphatic vessels and thoracic duct are accessed either transabdominally or intranodally, so that dye can be injected to highlight where the thoracic duct is. The video on the left shows a thoracic duct in blue, now connected to the external jugular vein. The video on the right is a subsequent fluoroscopy showing a patent connection between the 2 systems. So now that we've reviewed imaging and possible interventions, the remainder of my talk will be reviewing cases of neonatal lymphatic flow disorders. When there is overproduction of fluid or conduction abnormalities, it can result in lymphatic fluid perfusing abnormally to various organs. When lymphatic flow is just to the lungs, it results in pulmonary lymphatic perfusion syndrome. And when there is abnormal flow to 2 or more compartments with the presence of edema or anasarca, it is referred to as central lymphatic flow disorder. Patients with CLFD have either a congenital absence of their thoracic duct or an anatomic obstruction. Some patients develop a functional thoracic duct obstruction, which typically occurs in the setting of elevated central venous pressure from a clot in the venous system. It can also occur in the setting of high intrathoracic pressure that we sometimes see in our patients with bronchopulmonary dysplasia. This is a case of a 27-week gestation triplet who was one of the first patients evaluated and treated for a lymphatic disorder at the Children's Hospital of Philadelphia. At 2 months of age, she developed bilateral chylothoraces, which were medically managed with chest tubes. At 4 months of age, she had a tracheostomy placed for BPD. This picture was taken after her tracheostomy was placed and shows how severe her anasarca became. We believed her dramatic swelling was secondary to increased central venous pressure and disruption of abnormal lymph channels in her neck. The video and image here were taken from her MR lymphangiogram and shows dermal backflow in her abdomen, abnormal lymphatic perfusion to the lung, and a lack of flow from her thoracic duct to the venous system. Given these findings, she met the diagnostic criteria for central lymphatic flow disorder. This video and image were taken from the direct lymph angiogram that was done to better assess her thoracic duct and shows her abnormally dilated and tortuous duct with insufficient drainage from the outlet to the venous system. Because of these findings, a decision was made to externalize her thoracic duct to allow her lymphatic fluid to drain outside of the body and reduce her body wall edema. This is the video and image taken during that procedure. You can see the introduction of a wire from the region of the neck that was directed into her thoracic duct. This wire was then used to place a catheter in the duct that ultimately drained lymph fluid outside of her body. Shortly after this procedure, she began draining about 1 liter a day. The graph on the left here shows her daily drainage for the first 3 weeks, and the one low point in drainage occurred when her drain was occluded, and it began picking up again after it was flushed. The graph on the right shows her weight loss over time. These are the before and after pictures. The picture on the left was taken soon after she came back to the NICU after her externalization, and the one on the right was taken 2 weeks later. So as you can imagine, during this time, her ventilator requirements greatly improved. We have had other similar patients in which thoracic duct externalization has been used to reduce overall body wall edema, allowing for surgical interventions, specifically lymphovenous anastomosis. Earlier, I mentioned that bronchopulmonary dysplasia can also lead to lymphatic dysfunction. Severe BPD is a heterogeneous disease that affects the lung parenchyma, pulmonary vasculature, as well as the proximal and distal airways. These abnormalities can lead to dynamic hyperinflation in some infants and can result in air trapping and high intrinsic PEEP. If there is a high PEEP requirement or the intrinsic PEEP is high, this leads to increased intrathoracic pressure, which in turn increases central venous pressure. This disrupts lymphatic drainage from the thoracic duct and can result in anasarca and other downstream abnormalities like protein-losing enteropathy and ascites. Increasing chest wall edema and abdominal competition requires additional increases in PEEP to overcome, and the cycle continues. This next case is a patient also with CLFD. He was born at 24 weeks gestation and was transferred from his birth hospital at 6 weeks of life. When he was 6 months old, he had inguinal hernia surgery, and ascites was found during that procedure. The fluid had 97% lymphocytes, and because of a history of loose stools and intolerance to feeds, a stool alpha-1 antitrypsin was also sent. The chest x-ray on this slide is significant for hyperinflated lungs with diffuse areas of air trapping, as well as soft tissue edema. So at this point, it was becoming more and more apparent that he was developing a lymphatic disorder. This is a video taken from a conventional lymphangiogram done to assess the thoracic duct outlet. This is not the same patient, but essentially shows no flow of contrast from the thoracic duct outlet to the venous system, and instead you see contrast pooling up into the neck. This is a subsequent video taken after the PEEP was weaned, and now you can see a steady stream of contrast from the thoracic duct into the vein. Here is an image from his MR lymphangiogram. He had a large and tortuous thoracic duct, as well as a significant amount of contrast accumulating into his duodenum. Other findings were dermal backflow and leakage of contrast into the peritoneal cavity, which you can't see on this specific image. So with these findings, he was diagnosed with CLFD as well as protein-losing enteropathy. PLE is characterized as an abnormal hepatoduodenal lymphatic leak that results in the loss of proteins. Single ventricle palliation surgery is the most common cause of PLE due to lymphatic dysfunction. The main protein that is lost is albumin, and many of these patients will present with hypoalbuminemia in addition to anasarca and ascites. The diagnosis can be made by finding elevated alpha-1 antitrypsin in the stool. In our patient, his PLE was due to a functional obstruction of his thoracic duct outlet from high PEEP, both ventilatory and intrinsic, and so selective embolization of the leaking channel would only be a temporary solution. The main goal in this case was to reduce his intrathoracic pressure by externalizing his thoracic duct. So the next category of lymphatic disorder we commonly see in neonates is pulmonary lymphatic perfusion syndrome. PLPS is the result of abnormal lymph flowing retrograde from the thoracic duct to the lungs while the remainder of the system is normal. When it occurs in infants, it results in neonatal chylothorax. Although this pattern is believed to be secondary to abnormal fetal development of the central lymphatic conduction system, it's also the same pattern seen in older adults who have plastic bronchitis. This study, published in 2018, described the correlation between the prenatal finding of nutmeg lung and postnatal imaging features of neonates with lymphatic disorders. Nutmeg lung is a term used to describe a fetal finding of abnormal pulmonary lymphatic flow on MRI. It refers to a heterogeneous T2 lung signal that looks like a cross-section of a nutmeg. The authors of this study showed that patients with this prenatal finding had PLPS and chylothorax that was then confirmed on postnatal lymphangiography. The last case I'm going to present is a term infant who was prenatally diagnosed with a right-sided chylothorax. She had normal genetic studies and underwent 2 thoracoamniotic shunts prior to birth. At birth, she was asymptomatic and admitted to the NICU on room air. Enteral feeds were started with regular maternal breast milk, and as the feeds increased, she began to develop tachypnea and mild respiratory distress. The X-ray on the left was taken on day of life 0 and showed minimal pleural effusion. Due to her changing status, a second X-ray was obtained on day of life 4, and it showed an increase in the effusion size. At this point, she had lymphatic imaging done to determine if she could be treated, and this video and image was taken from her MR lymphangiogram showing an abnormal pulmonary lymphatic flow to the right lung only. A chest tube was placed and she was treated with intranodal injection of oil. Here is the fluoroscopic video of the oil injection, and you can see the contrast migrating up the thoracic duct and into the abnormal lymphatic channels on the right. A few days after this procedure, her chest tube was removed and she was placed on low-fat feeds without recurrence of her symptoms. So after several years of seeing patients with both CLFD and PLPS in our unit, we decided to take a look at the outcomes of our neonatal lymphatic population. We conducted a retrospective review of 35 patients. Even though it seems like a small number of babies, these are such rare diagnoses that this is one of the largest reviews of neonatal lymph disorders. In our cohort, there were 15 patients with PLPS and 20 with CLFD. The patients in the CLFD group were slightly more premature at birth. 80% of the PLPS group had a prenatal lymphatic diagnosis as compared to 40% of the CLFD group. And I think this is a reflection of the various causes of CLFD. All patients, regardless of their diagnosis, had a history of a chylothorax. Lymphatic imaging was performed on both groups of patients with MR lymphangiography. 85% of the CLFD group had ascites, and 42% had soft tissue perfusion as compared to the PLPS group, which had neither finding. On DC-MRL, almost all of the PLPS group had lung perfusion, but none had dermal backflow, while all of the CLFD group patients had dermal backflow. Following diagnostic imaging, 21 patients went on to have a lymphatic intervention. 11 patients with PLPS were treated with oil compared to 2 patients with CLFD. Of the remaining 8 patients with CLFD who received a lymphatic intervention, 2 received a combination of oil and glue embolization, 3 underwent lymphovenous anastomosis, 2 had their thoracic duct externalized, and 1 had a lymphatic vessel drain place that was not in the thoracic duct. We found that patients diagnosed with PLPS had 100% survival, while patients with CLFD had only 50% survival. All 15 patients with PLPS had resolution of their chylothorax, including the patients that resolved without an intervention. We concluded that MR lymphangiography, or DC-MRL, is a useful tool in determining diagnosis, directing treatment plan, and providing important prognostic information to families. We also learned by visualizing the extent of lymphatic disruptions, we can develop more targeted interventions for patients with CLFD with the hope of improving outcomes. Thank you very much for your time, and I'll be happy to answer any questions you have during the Q&A session.
Thank you very much, Dr. Dalat, for a really very interesting presentation. And we're going to be joined by Dr. Faisal, Dr. Kumar, and Dr. Junaid Khan for the panel discussion. We have a few questions already received for all the presenters. I will start with Dr. Kumar. HLH diagnosis, as you mentioned, you need like 5 out of 8 criteria for the making diagnosis. Now, sometimes we have the diagnosis made based on, for example, like high ferritin level or high fibrinogen levels. And then when we decide to start the treatment, those levels will drop below the threshold to be diagnostic. So the question is that, is it, to make a diagnosis, the only needed to have that threshold exceeded once, or you have to be persistent in the higher numbers?
Right. So for making the diagnosis, once is all you need. I continue to remind, that is the biggest message, that using those criteria of meeting 5 out of 8 is not sufficient to make the diagnosis. It is sufficient to make you suspicious that could this be HLH, but it could be many other things, or the HLH is triggered by an infection. And the last thing you want to do is give a baby who has an infection, give them steroids and etoposide. So be very careful in making the diagnosis. You can definitely suspect it, but to answer that question, one-time elevation is all you need.
Great. Thank you very much. And Dr. Faisal just joined us. Welcome, Dr. Faisal, to the discussion. Can you hear us?
Yes, yeah, I'm hearing you now.
Okay,
I just
very good. Very good. We have many questions about your presentation. The first question I have from the audience is that if you have an increased PT and APTT due to TPN-induced cholestasis, then what's the course of treatment or evaluation?
See, you have to know that if you have prolonged both, which is extrinsic intrinsic pathway, and we know that vitamin K is a fat-soluble, the vitamin, So in that area, as we know, because of prolonged TPN, and I think I mentioned in my presentation that those babies on prolonged TPN need to be given factor 7, the vitamin K. So if you can try to correct it with vitamin K, and it will be corrected unless, if the vitamin K, or if patients going for any procedures, and on urgent basis like a neonate, then you have to give FFP. Otherwise, you just absorb them or need an extra vitamin K to correct it in that scenario.
Okay, great. Thank you very much. Dr. Taha, a question about the technology of the lymphatic mapping. Many times in neonate, as you know, we see babies who get sepsis and they get severely edematous. And we always think about the either hypoalbuminemic or because of sepsis and third spacing, they get a lot of fluid leaking into the interstitium. Now, if we would suspect lymphatic obstruction for those babies, is the technology that's available everywhere that's to do for example, CT imaging, or does need to be certain like software or technology available to do this?
That's a great question. I think 5-6 years ago, there were only a few centers doing the DC-MRL or MR lymphangiography specifically. And each year we have more and more centers calling us, sending us MR lymphangiograms to review. So I think it's becoming a little more widespread. The only technology you need other than an MRI machine is an interventionalist who can insert intranodal needles followed by the injection of gadolinium. This is the preferred first step for imaging because it does show the lymphatic flow, and certain defects in the system can then be isolated. What gets a little trickier is if you need to get a better look at the thoracic duct outlet, but we're hoping more information on ultrasound with contrast of the outlet would be helpful, that other people can adapt that use.
Okay, and once your imaging is done, now is this something that you need? What expertise is it? A radiologist who is going to be reading this, or do you have special training to do the reading for the lymphatic imaging?
Radiologists are reading the images at our center, and I think that's being incorporated in a lot of training programs so that the new generation of radiologists are reviewing the imaging. But all of our interventionalists who perform the DC-MRL can read the images, and most of those physicians are interventional cardiologists.
And once the obstruction is diagnosed now, we know that as neonatologists we do some, modification of, for example, like lipid intake, feeding with MCT and all that to decrease the lymphatic flow. And so when do you say, this need to go to surgery, not to go with a medical treatment, either like by medication or by modification of feeding?
All of our patients who present with lymphatic disorders are treated medically first, including the low-fat feeds. In diuretics, fluid resuscitation, removal of excess fluid and cavities that can have drains placed. And so the initial first step is, one, to make the diagnosis of a lymphatic disorder by obtaining fluid, either pleural fluid or ascites, and then trialing medical management before we take that for invasive imaging. And so that's usually our first step. And most of the referrals we receive at our institution, these medical management steps have been taken before they call us. So usually we see the patients who failed medical management.
Dr. Junaid, do you have any questions?
I have a question for Dr. Faisal, who is not around.
No, I'm not sure if Faisal's still connected.
Yeah, sure. No. Okay, go ahead.
He's here. Okay.
I'm doing between just in the clinic. Yeah, go ahead.
Oh, okay, Faisal. The one question is about the neonatal bleeding disorders. If a baby have a low platelet counts and nothing else, no signs and symptoms, no purpura, no rashes or no anything, how you take this thing as a diagnostic? That what is your diagnostic? You wait for a while, or you just act on that?
There is. I think I will. I think if you read my presentation, I mentioned on a diagram where you see that there's a different causes of low platelets, which I say patient with thrombocytopenia or not thrombocytopenia. And what you're describing is normal baby, which is not sick looking.
Yeah.
And then you have to, a normal baby, which is not sick looking, then you have to, make sure, I ask you to do a family history from the mother. Is mother, she known to have low platelets from herself, or she have an ITP before? Because sometimes even she resolved, there's some antibodies which cross. And this is a cause. And sometimes the commonest error is, is iatrogenic. When you do a CBC on a child in neonates or a clotted sample or something, or if it's not full properly, the tube. The other is called, we sometimes, with E-data, you see a clumping of the platelets. So sometimes when we have a doubt, if a normal baby I will ask for citrate platelets and it will clear it out. But unexplained thrombocytopenia, you have to look for a cause. And sometimes because of stress or any, baby have, birth asphyxia, it may give it to you. But again, when to transfuse at what platelets level is a debate. But again, if the patient is not sick looking in neonates, we will not do anything. If below around 20 or even 10, we have to wait for it. But the commonest problem is when either the nurse collect the sample or is the physician collect the sample. Another part is collection error. They have to rectify it first, double check, make sure the right way, and then you diagnose of exclusion.
I have a question for Dr. Taha. Dr. Taha, you are hearing me? Yeah. So about the feeding of the baby with the lymphatic disorder, what do you recommend? There's a lot of debate with our dietitians, with our other colleagues, physicians. Do you have any specific recommendation? You said that initially you start with the low-fat feeds. So what can, let's say the breast milk is available, but other than that, what do you suggest?
I'm glad that you asked that question, because that is probably the number one thing I get asked from other physicians and other institutions, and within our own division as well. It's a hot topic, and we typically recommend low-fat, long-chain. So the fat that we want to avoid is long-chain fatty acids. So any formula that's low in that, if I can give some brand names without endorsing them, Enfaport is the only FDA in America approved formula for infants. However, it has slightly more fat content than Monogen. So our first line is Monogen, and that's what I would refer to other hospitals. In terms of breast milk, skimming breast milk with allowing it to layer out and then separating the fat off the top has only been shown to reduce the fat by about 20%. Whereas if you have a centrifuge and you skim the breast milk in a centrifuge, those studies have shown that the milk is actually 99% fat-free. And so if you have the ability to skim in that way, we would recommend using centrifuge first and then adding some formula for additional calories. I have veered away from recommending that because it actually, you have to discard quite a bit of the breast milk. So I will tell people to freeze their breast milk, put it in a deep freezer, because we hope that in a few months we've resolved the lymphatic disorder and we can introduce full fat feeds with breast milk.
Okay. Eamon, I have one question for Ashish also. Ashish, a very nice presentation, and if for you, if this question is like a very basic or stupid, so we are just a neonatologist, so baby delivered, and we suspect HLA. At what point of a time we should consult with you? Okay.
I would say, making sure you can hear me, yes.
Yeah.
Anytime. It doesn't matter if you are suspecting, I would say, let's put it this way, that if you think you want to start therapy before you give this baby immune suppression, and if you want to make sure, then give us a call, shoot me an email, and reach out to any of us. Faisal actually has had several encounters with me on this particular question. So any of us, you can reach out just to be sure that we're not missing. And the biggest challenge that even we face, most of these emergencies happen in the middle of the night or on the weekend, or at a time when you don't have the labs. So you have to make a decision. And in that situation, always save the patient first. And just know that we acted upon incomplete data, but that's what you have to do. Once you save the patient, then we can still confirm the diagnosis. We can do everything even after you've started therapy. The only challenge we run into is if it was a leukemia or a lymphoma, now you've partially treated it. But even then, with the genetic studies, if those are negative, then we can always stop the therapy and wait for things to unfold. So it might take a while, but if you suspect and the child is deteriorating, by all means, start the treatment, save the child first, and then we will worry about confirming the diagnosis later. But you can reach out to us at any time.
Yeah, and to addition to this question that,
Judith, can I comment something about here? Just to
Sure.
Sure. I think I agree with Ashish, but one thing I think Eamon knows it, some of the kids are only presented in neonates only with a liver failure. Apart what you describe, any patient with acute liver failure in the neonates, you have to think about HLH in this part of the world. We have a couple of cases in our NICU. I think Eamon knows about it. It came with QD, acute hepatitis, and the neonates turn out to be HLH later on. So, and we need to be very low threshold in our part about HLH, even in NICU.
So my question is related to all this, that, okay, there is chances of HLH or any disease, and usually in NICU, these type of babies, we start with antibiotics, and they are immunocompromised, and then therapy is immunosuppression. So how you deal with that situation, Ashish? Sorry for my very basic questions.
No, these are not basic questions. These are the challenges that even we deal with on every day. So yes, the disease itself causes, yes, it's an immune defect, but the HLH disease by itself does not make the child susceptible to infections.
Okay.
It is our treatment that is a bigger contributor to the risk of infection. And of these treatments, I think, believe it or not, it is the corticosteroids that are the biggest challenge. And so we are now moving towards newer treatments that hopefully will be less immunosuppressive. And that is the part that I skipped over. I did not finish it in the interest of time.
Sure.
But we now have new treatment that is approved, at least in the US. It is not approved in Europe at this stage. and that is Gamifant, which is a monoclonal antibody against interferon gamma, known as imapalumab. And I think it is available in the UAE, or at least the company is trying to make it available. And the advantage of these treatments is that they block the cytokine without eliminating or causing immune suppression. So, unlike etoposide that will cause neutropenia, these drugs don't do that. So, currently it is approved only as a second-line agent, but hopefully in the next few years we will learn more. But I completely agree with you. The risk of infection is high, so we have to use prophylactic antibiotics, antifungals, and making sure that we give IVIG and supplementation, but also knowing that we should use as little immune suppression as possible just to keep the disease under control. You don't want everything to become normal. The ferritin in primary HLH will not normalize, and we don't have it to be normal. If the baby looks well and is able to, the liver function is staying normal, then I think bringing things in the safe range is all we need, and using the least amount of immune suppression. But this is even in our part of the world, it remains a very challenging disease, especially in young infants. It is still a big challenge.
And
I want to update you about a couple of things what Ashmi says. This Gamifant is already registered in UAE, it's available. We use it for a couple of patients, I think, in refractory cases. The other thing is, as Ashish said, immune deficiency, immune dysregulation, and we are using BCG here. We come across a couple of patients with immune deficiency, trigger secondary or HLH, and then on the top of fulminant TB. So I'm not sure do we have to revise our policy to give a BCG upfront here? I'm not sure, because we faced a couple of cases like this. Patient received BCG and have a fulminant because of immune deficiency, develop secondary HLH on the top of the infection, and it's difficult to treat with steroids in this kind of scenario.
Yeah, I know, Dr. Junaid, or Dr. Faisal, that Saudi Arabia, they moved actually the dose of the BCG to 6 months instead of giving it at birth, just for a chance to have the baby have immune deficiency. They worry about kids basically, but if this is can be maybe thought of or implemented, that's a good thing to delay. I know US they don't use BCG, but here still BCG is part of the neonatal care.
Right. Well, we don't have TB is not endemic in the US, so yes, our populations are different. But Faisal, that's an excellent question to be considered. But you have to balance that with will the families return promptly at 6 months for the BCG? Those are the questions. I bring this up because I trained in India, and that is a big challenge we face there in the rural communities. When the child is born, that is your chance to give them all the safety you can provide, because they may not come back for the next immunization. And TB being endemic, that's what we focus on. But
now, follow-up here is very good, actually. UAE
that's great. Right. In that case, then perhaps delaying BCG, Faisal, that's a great idea.
Yeah.
Sorry, Dr. Junaid Khan, you had another question.
No.
I think we have to wrap up because we have a lot of questions coming from you, but the time is really getting a little bit more than what they expected. But it's really great session. I would like to thank all the speakers for a very informative session. Dr. Ashish, Dr. Dalal, and Dr. Faisal. Thank you very much. It was a very good session, and please, if you can join us for the rest of the I know Dr. Dalal is going to join us for the rest of the 2 days. Dr. Ashish, you're welcome to stay with us for the next 2 days. Thank you very much for all speakers. Thank you.
Thank you.